Welcome to The Explainer. Today, we are unpacking a really fresh clinical update on the approach to Hirsutism. This is all based on a fantastic 2025 review by Ricardo Aziz and his international colleagues. Now, for us endocrinologists, this is a bread and butter presentation, right? But its workup is just full of these important nuances. So let's dive right in.
Here's our roadmap. We'll kick things off with the clinical challenge, then get into the diagnostic toolkit and how to navigate the differential. We'll ground it all with some really telling case studies, cover modern management, and wrap up with what's arguably the most important part, the patient-centered imperative.
So, first up, the clinical challenge. Hirsutism is so much more than just a cosmetic issue. It is a critical clinical sign, often our first clue to an underlying androgen excess, and it carries a heavy, heavy burden for our patients.
And the scale of this problem? It's huge. We're talking about roughly 1 in every 10 women around the world. So, this is not some rare bird we're hunting for. It's a daily reality in our clinics.
The authors here are basically speaking directly to us. They're saying, look, whatever you think the patient's distress level is, don't underestimate it. They call it a profound disruption. And that psychological weight is exactly why we owe our patients a thorough, empathetic workup every single time.
Okay, let's gear up. We're moving on to our diagnostic toolkit. This is all about making sure we have the right tools ready to go for an efficient and, most importantly, accurate assessment. So the official definition, as we know, hinges on the Modified Ferriman-Galway score, the MFG. But the really key update here is the diagnostic threshold. The 2023 International PCOS guideline has shifted things, now recommending a cutoff somewhere between 4 and 6. And that's a big deal, because it's based on newer population data and acknowledges ethnic variations.
And here are the 9 spots we're looking at. The MFG score isn't just a random guess, it's a systematic assessment of these specific androgen-sensitive areas. Each site gets a score from 0 to 4. It's our standardized way of getting a baseline and, just as crucial, tracking how well our treatments are working down the line.
Now for the initial blood work. The evidence really points to this high-yield 4-test panel to start. The authors hammer this point home. You need a high-quality total testosterone assay, ideally LC-MS/MS. Then, a 17-OHP drawn in the early follicular phase is absolutely essential to screen for NCAH. TSH and prolactin round it out to quickly rule out other common culprits.
All right, we've got our tools. Now let's use them to navigate the differential diagnosis. Honestly, understanding the odds, the prevalence of each cause, is the key to not getting lost in the weeds.
Think of this table as your clinical anchor. Of course, PCOS is the dominant player, right? 80, even 90% of cases. But you cannot afford to stop there. Look closer. Non-classic adrenal hyperplasia could be present in up to 1 in 10 of these women. And while the androgen-secreting tumors are rare, we're talking 1 in 500 to 1 in 1,000, they are the life-threatening diagnosis you absolutely cannot miss. This data literally frames our entire workup. Okay, theory is great, but let's make this real. We're going to walk through a couple of cases straight from the review. These little stories are the best way to see how these principles actually work in the clinic.
So, first up, a 31-year-old woman. The story sounds pretty standard at first. Her symptoms started around puberty, she says her cycles are regular, and her MFG score is 13. Your mind might immediately jump to PCOS, or maybe idiopathic hirsutism.
But then, the labs come back, and here's the plot twist. Her baseline follicular 17-OHP is 4.7. That's more than double the screening cutoff of 2 nanograms per milliliter. And that one number, it changes everything. It yanks our attention away from PCOS and points us in a totally different direction.
And this is the path that single lab value sets us on. The elevated screen triggers an ACTH stimulation test. And boom, her 60-minute stimulated 17-OHP is 65.4. That seals the deal. The diagnosis is confirmed: 21-hydroxylase-deficient non-classic adrenal hyperplasia, a classic PCOS mimic.
Okay, case number 2. This one is flashing red flags from the get-go. We've got a 46-year-old woman.
She was doing fine on birth control pills, but after she stops them, she develops this really rapid, really severe hirsutism over just 8 months. Her MFG score is all the way up at 22. That late onset and that speed, that should make the alarm bells in your head go off.
And her labs absolutely confirm our fears. Just look at that total testosterone. It starts at 364 and on repeat is over 500. That is sky high. And here's the critical piece of the puzzle. Her DHEAS and androstenedione are totally normal. This specific pattern, super high testosterone with normal precursors, screams autonomous production from a tumor, almost certainly an ovarian Leydig cell tumor in this case.
Which brings us to this absolutely vital clinical pearl. We all have these testosterone cutoffs in our head, right? Like 150 or 200. But the review makes it clear, the single best predictor of a tumor is the story. It's the clinical history. That sudden progressive onset of symptoms, especially happening long after puberty, is your biggest clue. Trust your gut on this one.
Okay, with that diagnostic framework firmly in place, let's switch gears to treatment. We're going to cover the evidence-based therapies we have in our arsenal today.
So our medical therapy really rests on 2 main pillars, and they work in different ways. On one hand, you have combined oral contraceptives, COCPs. They're first line and they work upstream by shutting down ovarian androgen production and bumping up SHBG to sop up free testosterone. On the other hand, you have anti-androgens like spironolactone. They work downstream, right at the site of the problem, blocking the androgen receptor on the hair follicle itself.
So, the big question is, which approach is better? This chart, which pulls from big network meta-analyses, gives us a pretty clear picture. COCPs alone, they work. Anti-androgens alone, they also work. But putting them together, that's where you get the biggest bang for your buck. For maximum medical effect, the evidence is solid. Combination therapy is the way to go.
Now, these are 4 absolutely critical counseling points. Number 1, you have to manage expectations. This isn't a quick fix. Tell your patients it's going to take at least 6 months to see real improvement. 2, safety is paramount. Anti-androgens can cause birth defects, so reliable contraception isn't just a suggestion, it's mandatory. 3, when you're choosing a COCP, the type of progestin matters way more for VTE risk than for hair growth. And 4, metformin is not a primary treatment for hirsutism. It's an add-on, an adjunct, for your patients who also have insulin resistance.
And for our final section, we're coming full circle. Let's bring our focus right back to the person sitting in the exam room. This is all about treating their distress, not just chasing a number on a scorecard. I mean, just let this quote sink in for a second. It's so important. The research is clear. How a patient feels about their hirsutism is a much better predictor of their quality of life and their risk for depression than our objective MFGO score is. What we see and what they experience can be 2 very different things.
So this explainer really leaves us with this one final challenging question for all of us. In our day-to-day practice, what are we really trying to do? Are we treating a number, the MFG score, or are we treating the patient's very real, often very profound personal distress? And the answer to that question, well, it should guide everything we do.